Good evening, all. My case is a vitreous hemorrhage from an unknown cause. This is a male patient, 50-year-old. He was post-COVID 15 days. He came with sudden painless loss of vision since 3 days in left eye. He's a known diabetic who is on insulin. The right eye was 624 and the vision loss is contributory because of the posterior and anterior capsular cataract, and the left eye was counting fingers close to face, and he was pseudophakic who was operated 2 years back. This apparently it looked like a simple PDR to me, so I didn't take a fundus picture of it, thinking it's a simple PDR where we could see a NVE in the right eye in the superotemporal quadrant, and the patient had subhyaloid hemorrhage and NVD. So we advised pan-retinal photocoagulation to the patient, and meanwhile he said he's not able to see with both the eyes clearly, so he underwent right eye cataract surgery, and the left eye we did a PRP, possible PRP, and then we gave a Avastin injection. So the right eye was still the same, and so we advised pars plana vitrectomy. The patient underwent vitrectomy and everything looked fine. His vision also improved to 612 and everything went on well. And post 1 month post surgery, patient came with diminution of vision in both the eyes, 624 and 618, and there were cells in both the eyes. Apart from that, we couldn't find any KPs in the eyes. And this is how he presented to us with serous retinal detachments and deep retinal hemorrhages in both the eyes. And in left eye, we could see disc hyperemia. Then we did an FFA and patient had vomitings in between, so we had to stop FFA in between, and we could only take these pictures. There was an NV and we could see lot of multifocal areas of pinpoint leakage and large placoid areas of hyperfluorescence, and there was this staining in the other eye. I took an OCT. Patient had this subretinal detachment with septate formation. Then his sugars were not under control to start him on steroids, so I asked him to come back after an endocrinology opinion, and within 2 days this is how his OCT has turned out to be. There were multiple pockets of subretinal fluid with septic. Then I thought it is sympathetic ophthalmia because he was operated in both the eyes, right eye and left eye vitrectomy. So we started him on a standard protocol, that is 1 gram IV methylprednisolone for 3 days and then oral steroids with tapering over 2 months. He was doing all good for 4 months, around 4 months, and then around in November, he came back to us with decreased vision in right eye and cells. He was on maintenance dose with oral steroids. So then we could see a subretinal membranous fibromembranous structure which is present in between fovea and the disc. He had developed a CNVM. So then we seeked a rheumatologist opinion, thinking he should be started on an immunosuppressive, and he was started on Azeron, azathioprine 50 mg BD after ruling out the infection and other connective tissue disorders. And we concurrently injected him with ranibizumab 3 doses. So I asked him to send me a WhatsApp picture so that I could see him what the rheumatologist has told, and that is when I saw his WhatsApp picture, and there was vitiligo which was always which I didn't notice because he was always wearing a mask post COVID. Then I asked him to send me a clear picture of how he is, and this is how I could find the vitiligo around his lips. Then I asked him if he had any signs of headache or meninges. He said he had stiffness of neck. So then I changed my very first diagnosis of PDR to a proliferative retinopathy as a feature of VKH syndrome. So we gave him 3 injections of ranibizumab, and this is how it is. And he had another episode of recurrent VH in his left eye. Then later we stepped up his immunosuppression to MMF 2000 mg, and he was already on Azeron and Vicelone. Then we saw a recurrent episode of anterior granulomatous uveitis. Then he was then stepped on to biologic agents. So to say it is an uncommon feature of VKH, duration of presentation and development of retinal vascularization can happen in between 6 months to 1 year. The cause of proliferative retinopathy in VKH is probably because of long duration of either treatment discontinuation or suboptimal dosage. My conclusion is proliferative retinopathy is an uncommon feature of VKH in patients with suboptimal control of their inflammation. Proper uveitis management is very essential to cause regression of this retinal neovascularization. Thank you.
Hold on to the last slide only. Patients are non-diabetic,
10 years, sir.
diabetic.
From past 10 years, he was not controlled already on insulin.
It's very, very confusing presentation. Very, very confusing presentation. But I think ultimately it was VKH, but VKH requires, this picture is typical for VKH. And
So,
VKH
but
requires
as
treatment for years and years.
yeah.
Years and years on immunosuppressors. And it's not, you know, 6
So
months.
one thing why I excluded VKH because he was surgically operated. That is one of the criteria we say there should be no previous history of surgery or an ocular penetrating trauma. So though I knew it looked like VKH, but still I couldn't put into it because there was a recent history for 1 month back.
And VKH is one disease where steroids will not work fantastically.
Yeah,
You
and
have
in
to
spite of putting him on azathioprine and MMF, he was still deteriorating. He developed inflammatory CNVM, he developed anterior granulomatous uveitis, so he's moved on to biologics.
You see, VKH can, because VKH ultimately is a choroidal disease, it can develop CNVM. That's not a very big issue. And you have tackled very correctly, but only thing is, you know, we started with laser and diabetic retinopathy.
That's because I could only
hemorrhage.
see SHH with an NVD in one eye and the other eye had NVE, so I thought it was a simple PDR. So we started with treating it as a PDR, but
So
it
in
tried.
retrospect, do you think that it was proliferative retinopathy or proliferative diabetic retinopathy?
It is a proliferative, I think to start with, it was a proliferative retinopathy of a VKH case, which I have misdiagnosed as a PDR. So I just wanted to enlighten that cases like this can
So
happen.
you should label this patient now as VKH in a diabetic patient. No?
Yes.
What do you say so?
No, it's quite confusing. You know, in your earlier picture where you saw the survivor hemorrhage, it didn't have any other signs of VKH.
No, there were no
No
cells,
inflammation,
no
nothing.
cells, no.
It might have been a diabetic
And he
retinopathy.
actually improved well post surgery also.
It might have. It can be.
Yeah.
It can be a diabetic retinopathy and later on developed an episode of.
No, but the hemorrhage, these
See,
dot and dot
I think
hemorrhages.
Vivek Som has a point. In a patient who has a proven subhilar hemorrhage with PDR, he may have developed VKH.
Post
Yeah,
laser.
but there are case reports
But
where there is.
did you get his renal parameters done?
Yes, the normal.
Because you see, a lot of patients with PDR, if you get some cystic swellings, uveal effusion is very well known in renal hypertension also. In a patient with renal hypertension,
No.
you see, you should get his kidneys evaluated very
Yeah,
nicely.
kidneys are all normal.
Yeah. But the OCD picture is typical. But you know, I had one lady long time back where we published also that renal hypertension, you know, having a picture like this. So I was going to ask you, but this fundus actually looks too good for renal hypertension. But
Renal could also have multiple exudates.
yeah, multiple.
After this,
And this is
because he had uncontrolled.
those typical studies.
So at the end of it, you are still leaving us in a confused state of mind. That you know, personally, I would agree. Normally, this kind of proliferation NVE we don't get in VKH. CNVM you definitely get, but this kind of NVE you don't get in VKH. Any opinion from anybody else? Yeah, yeah. It's a PDR. It's a PDR primarily, where
Maybe
you can explain NVE. You can explain that large subhilar hemorrhage also with PDR, but
sometimes, you know, autoimmune disorders are sometimes precipitated in
And
some
he was
cases
all
by
normal
trauma.
for.
So maybe you did laser and after that, you know, that thing precipitated in Neha.
So laser was done in 2021 December, and he developed this in around
and
March.
when did you give steroids?
March, July. The minute he developed, March 2022 is when he has developed the VKH picture.
3 months. Just speculating. It's a confusing
Yes,
area.
yes. Simpler Salmi, yeah, yeah, I heard that. Yeah, 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 yeah.
Vitiligo it can be present in them also, but how long probably I'm not very sure that when a sympathetic ophthalmia will develop a vitiligo like picture, The only differentiating point, as Madam has already mentioned, is
After
presence.
surgery, did the patient develop this kind of symptoms?
So the cataract was done in November in right eye, and vitrectomy was done in February 2022,
And
and he developed it in March.
the history of vitiligo was there since.
Since long
It
time.
was there since long time.
So therefore, what you were saying now that vitiligo is there, I think for ages.
Yeah. That was. This is his photograph from past 3 years old. It is his WhatsApp picture. That is when I asked him send me your actual picture, and he resent it.
Written automatically. So his question,
Audiometry here.
his question will be answered.
Chalo. We still are confused actually what's going on, but worth presenting, and food for thought for everybody.
It was a very good presentation, and as always, the only thing I like to tell all the presenters that none of you gave the financial disclosures, which is very important for presentation nowadays. You know, when you are presenting, you should give a financial disclosure. And the second thing is all the cases were very nice, very nicely documented, and we had a very good discussion. It's always a pleasure to be with you, sir, and we always learn. Thank you.